have pretty much, and as you know, I stepped into the job February 10th at 10:15. I don't want to be specific, but that's when the email blasted out and said that, number one, I was the acting director, effective immediately, and about 5 minutes later, I called Admiral Grinnell and said, help! Because up to that point, I had supervised all the area directors as the deputy director. And so very quickly, we started moving. But I have worked very closely with Dr. Rubidoux, and I have the absolute utmost respect for her. And it's, you know, and talking to her about the priorities and how to sort it down, that the process just very quickly happened. I believe in these 4 priorities. I think they keep it simple. And I just made a change in the first priority. And as you can see, the change is end urban Indian health programs. Because of the conferring, and our partnership rises to the same level. And I say this because I think all of our senior staff, including the area directors that are here, it's about how we communicate, how we dialogue, and how we cooperate with, and I think I've heard that term several times yesterday by Mo, the cooperative agreement. But I think it's really crucial that we keep these priorities and keep them focused, because we have made a lot of progress on all of them, and all of them speak to 4 different parts of our agency. And certainly, let's go to the next slide. In September, as it was talked about, we initiated the confer policy. Then we held 3, as Donna said, 3 confer sessions. And so we're kind of picking up speed a little bit. We're conferring at every opportunity. I will say that I think in California, we actually did a confer session with the California programs in the afternoon, did the tribal listening session in the morning, and did the confer session with the urban programs in the afternoon. And so we're always open to that with every listening session. We've done 2. But I think that these sessions are really productive. We simply take every session and come away with things we need to work on, not only the board, but also us. And these conferences are critical because we begin to hear from more people as well. And certainly, as Dr. Rubidoux started this process with the confer policy and putting it in place, we'll simply move it, and as the first priority says, we'll strengthen it by virtue of this process. Next slide. As you know, previously there's been a lot of Dear Tribal Leader letters that are going out as another form of communication, and just a little bit about those, and then we'll switch over to the urban letters as well. But the first segment is there is a series of work groups that work on things, and then the agency decides, okay, we're in a good place. We're going to go ahead and send a letter out for consultation. A classic one is STPI. We send a letter out to all tribes talking about STPI and getting their comments and consultation on how we allocate, given the fact that we're in another switch year. It's not just sending the letter out. I think the important part is we ask for your comments. We ask for tribal comments. We ask for urban leader comments. Well, so we get all those comments. People say, well, what happened to them? Our process now is to then take all those comments, put them together, sort them down, and come back out one more time and say, this is all your comments, this is what you recommended we do, and this is what we're going to be doing. And we send that letter out and expect that either, you didn't agree with us, and I will probably get some communication on that, but at least it begins to close the loop. I think a lot of times that federal agencies will ask for your ideas, ask for your thoughts, and then you never hear from them again. And I think that's not responsible, and we're not gonna do that. We actually have, much like we have on the tribal side, There's a tribal site with all the tribal, Dear Tribal Leader letters. Now there's a site with all the urban letters also posted and all the requests. And we'll be posting that and completely doing the same thing in tandem with the tribal letters. And I think that those are crucial as we move forward. Now we talk about the appropriations of IHS in general. I think that we've had some fits and starts over the last few years. I think 10 was just a marvelous year. I was on my way out at that time, but I was able to initial off on a 13% budget increase, and it was great. But my talking point during those first few years was that our budget represents our commitment to American Indian Alaska Natives on or near reservations focused on clinical care. Translation, eliminate urban, eliminate CHRs, downgrade facilities construction, maintenance and improvement, and a lot. You look at the categories that we begin to eliminate. That was my rationale. So you can imagine how I just felt really good about 2010. Everything was restored. Current services was restored. We didn't have to worry about the urban program anymore because it was clearly being supported by the administration. So we've had some dark periods in our past, and I can certainly know of two of them. But the budget now is certainly moving in that line, and I think that this year there was an increase of 2.875, and we're actually looking at final comments and options to be able to circle back to you and based upon your feedback, give back to you where we're going with the 2.875, and there'll be a Dear Urban letter coming out. Slide 6. The projected budget, as you know, we didn't have any increases in 2016. However, I'm happy to share that the Tribal Formulation Work Group, as you all know, and I think it was referenced by Donna, that the tribal folks that recommended actually a $10 million increase in the urban line. And that's clearly a recommendation that we'll take seriously. I can't begin to talk about it. In fact, we're just starting to put together the 17 budget. I've already made decisions on what that budget is going to look like going forward to the Secretary, and I would be really violating some embargoed issues, but hopefully you'll be pleased back in when this budget sees the light of day next February. And of course, we'll keep you updated as we move along. Slide 7. We appreciate your continued partnership, and this photo is another example of this. This was the May 4th one that just happened this month. So and this is where we actually focused on data, and we'll talk more and more about data. Because as just a little footnote, Secretary Burwell is really interested in impact. What are we doing? What's the impact of what we're doing? And are people better off? And her talking point is when we leave, when they leave, and of course in 18, they want it to be in a better place. The American people, and certainly, and for our purposes, the American Indian Alaska Natives. And so we're all about data. This is an area that data speaks volumes for us, and it provides evidence-based justifications, and we've got to have it. And so I think it's something that Mo has referenced earlier, is an area that we've got to really work on, and we have to be consistent with our data. And we know that there are 33 different programs with 33 different sets of data and 33 different ways of gathering it. And I think that's the NCUI board is trying to pull that together so we can look at it and be able to present a more coherent picture for urban health and urban programs. Let's go to the next slide. The Affordable Care Act, I will speak just briefly. I know that our experts in the room, Mr. Jeff Roth, he's really done some deep dives into all the mechanics of the Affordable Care Act, and I don't pretend to know anything as much as he does about it, but accepting to know that there are some real positive outcomes that are happening across the country, particularly in those states that have had Medicaid expansion. We were just down to Albuquerque, of which I stole Admiral Grinnell from, and their Medicaid collections, just in a word, you've heard us talk about we can only do priority one, emergency care. Life or limb, that was our talking points. And Albuquerque has actually gone down to level 4, with 3 service units down to level 3, because they're not having to purchase care. People are being covered because of the expansion. So it's an interesting dynamic that's happening, and I think that we're looking at this, and I know that certainly Mr. Roth, he has been really at the forefront, and we've held 4 urban days of action in Houston, Dallas, Chicago, and Salt Lake City. Apparently they were through here just in the recent past, and I want to thank everyone who participated in these events because and really stepped up to get more tribal members enrolled, informed about Affordable Care Act and the marketplace. This is an area that has a lot of complexity, but the bottom line is it really can provide coverage. And we've even been talking about the possibility of using some abilities to purchase care in the marketplace by urban programs. But more to follow on that. I think there's some discussion that'll happen later, but this is really a critical area. Slide 9. There obviously are we were looking at this map yesterday, and it demonstrates that, and we want to thank all of you for all that you do. And while we're traveling around doing these listening sessions, and we're trying to mix in some visits to local urban sites, and as we move around the country, we've got some that are going through several of the cities that we've got a chance to. We want to stop in and say hi, and really enjoy the fact that they're and to appreciate what's really been going on in those urban sites, because whether it's outreach and referral or actually a full-blown outpatient facility, they're all based upon what that particular community has been able to do. And this is, and we will, part of our road show, if you will, I don't call it that, Admiral Patia, but that's what it is. We're going out and we're actually engaging local tribal leaders, and also, to the extent possible, actually visit urban sites. This is the first, I think I was just maybe a couple of weeks, about a month, maybe. Yeah, and we went to California for the first listening session, and it was, and my tribal chairwoman was there, and it was great, sort of being back home. It's nice to start off listening sessions in the friendly confines of home. But the fact was, it was really we spent the afternoon talking, and it was interesting for me personally, because I had been out there, and there were 8 programs when I was there. And most of them were outreach and referral. There were a few of them that were providing actual, had a dental clinic, or they had a medical center. But to sit there and listen to them go around and talk about each one of their programs, what they were doing, was extremely enlightening. I know that we enjoyed it, and it was an ability to really engage them and talk about what can we do for them. And that's what we're going to be doing as we go around the country, is to be able to have these sessions. But But it demonstrates how diverse, and the diversity, we always talk about 566 tribes, how diverse they are. There's not two alike. Well, we're finding out 33 urban centers, not any two are alike, because of your location, your population you serve, and the services you're trying to put together to meet the needs there. I just think that there are a lot of great things going on, and it's probably an area that we need to talk more about. There needs to be more knowledge out there, if you will, about the urban programs and what they're doing. Next slide. Actually, Dr. Carroll sent her up to the Ignace healthcare facility groundbreaking in Wisconsin. Actually, Dr. Ignace was actually on our staff for a while before he left and went up to be the CEO at his, I think it's his father, named after Dr. Ignace. The facility is going to provide comprehensive preventive and healthcare service for the Milwaukee urban Indian health community. And so we talked about it, and I said, no, Dr. Carroll, I can't go, but you go. And so she, and you'll see this happening with me a little different than any predecessor, is that I tend to use everyone at my behest. I'll be sending an area director at one time, or I'll be sending a member of the senior staff, only because I can't be every place I want to be, and so why do that, and why kill myself to try to get it all done? Because I got to last. I don't know how much longer I'm going to last, but I'm going to do as long as I can. But the most important part is that let's go to slide 12. I think there's a picture of the facility. This is expanding its clinic space by constructing 40,000 square feet facility, and this is an illustration of the future facility. But you can see this is what's happening, and certainly in Milwaukee. And I think that that just demonstrates you all are doing this. I mean, this is just what Wisconsin is doing, at least right now. The president decided to take a trip and went to Standing Rock. And while he was up there, and the First Lady met with some youth from Standing Rock. There was a series of other things. They invited those youth to come to Washington. It was really a great occasion because the president and the First Lady decided to take the kids, put them in those big black SUVs, and run off to a pizza place. These kids they were frank with the president about what they were living through, and one particular young man had lost a sister to suicide. And that kind of impression has spurred the president on, and so now we have a generation initiative, indigenous program that he's put in place. And for our 2016 budget, you see $25 million. That's just, we think of it like a first down payment, along with a comparable part over in the Substance Abuse and Mental Health Administration, otherwise known as SAMHSA. They have $25 million, and we're going to try to work together to make the best of that $50 million that will be available certainly with the Congress's approval to move forward. And the focus is going to be on Indian youth. And I've asked Mr. Roth to be the lead for the agency with the White House and with the department on moving ahead on this initiative. It's a critical one. I know that Dr. Carroll, so there's kind of a team going on here, as Dr. Carroll's handling sort of the field work and internal, and I think the ADs have been hearing from Dr. Carroll on Gen I. And most recently, we're looking at ways to begin to hire youth, Indian youth, during the summertime using a departmental authority called Pathways. It's a summer student program. It's the old stay-in-school program, STEP program, but it's been retooled as a Pathways program. So we're looking at that as a possibility to in fact, to really move this along. And it's my take that there's certainly this is an area that we can. And I know you hear the newspaper is filled with just north of us here at Pine Ridge. There have been 11 youths have taken their life since January, and everyone is trying to figure out how to address this. And we know it's all going to have to be the community taking charge. But I think right now the community is just they're in a despair. I mean, it's how do they stop it? And now, I think the last was a 56-year-old man committed suicide, and it's just it's an area that we are going to focus on. But I think, as you all can appreciate, it's larger than just suicides. It's behavioral health in general, and we're talking about certainly meth and suicide, but it also starts with prescription opioids, and they just simply go to the street stuff later. So it's an area that I think this is one that urban programs can help to help us with this as we go forward. I think it's a really an important area. But moving ahead, certainly Jen and I just mentioned about the $25 million that we've had for 2016, and of course it's a focus on providing more mental health workers in the tribal communities. Go to 16, the next slide. I just want to say in closing, this is an update of what the Indian Health Service is doing. We're not letting up. I agree with you, Mo. I want to see the next year that this room is too small, that there are more people that are really concerned about what's happening in urban areas.